Very good morning, dear friends. In this third session of general anesthesia, today we are going to discuss about intravenous anesthetics. This intravenous anesthetics, these agents are used both as adjunct to inhaled anesthetics and as sole agent in short surgical procedures. For example, IV thiopentol, Itamidate, and Propofol have a fast onset of effect and are commonly used for induction of anesthesia. IV opioids provide cardiovascular stability, sedation, and so are used for maintenance of anesthesia and to provide anterograde amnesia. These intravenous anesthetics allow an extremely rapid induction because the blood concentration can be raised rapidly. But there is no channel for quick elimination like the lungs. Moreover, elimination of inhaled anesthetics can be hastened by inducing hyperventilation, while this is not possible with intravenous anesthetics. They get redistributed rapidly in the body tissues. These are used for induction because of rapid onset of action, and anesthesia is maintained by an inhalational agent. So let us discuss about inducing agent. The first most important is thiopenton sodium. It is an ultra short acting barbiturate which is administered parenterally. Sometimes extravasation of the solution at the site of injection produces intense pain, necrosis, and gangrene at the site. It rapidly induces hypnosis and anesthesia without analgesia. On IV injection in a dose of 3 to 5 mg per kg as a 2.5% solution, it produces unconsciousness in 20 to 30 seconds. Its effect remains for 10 to 20 minutes. It is highly lipid soluble. Duration of action is approximately 4 to 7 minutes. The advantages are quick onset of action, induction is smooth, rapid, and pleasant. Disadvantages: it is not a good analgesic and not a muscle relaxant, not a good muscle relaxant, you can say. The required dose for anesthesia results in delay recovery, respiratory rate, and circulatory depression of blood pressure. Therefore, it cannot be used alone. So, it is basically used in combination with other drugs. Adverse effects: a short period of apnea and enhanced respiratory secretions is there. Laryngospasm may occur. Overdose results in profound respiratory depression. Positive pressure ventilation has to be given to recovery. Severe hypotension and hiccup may occur because of this. The second one is propofol. It is an oily liquid and having short duration of action. It produces quick induction within 30 seconds and quick recovery take 4 minutes from a single dose. It is used for induction and maintenance for short as well as OPD procedures of up to 1 hour durations. The effect of single dose is terminated by distribution. It can be used for total IV anesthesia as continuous infusion or intermittent injections. It is a proconvulsant. So this is an important point. Then third one is Itamidate. It produces rapid onset and moderately fast recovery. It causes minimal cardiovascular and respiratory depression. It has no analgesic effect and causes a high incidence of nausea and vomiting. It has brief duration of action. For example, it acts only for 5 to 10 minutes. It has poor analgesic effect. It produces restlessness and depresses cardiovascular function as well as also depresses respiratory rate. It suppresses production of steroid, is not favored. Like barbiturates, rapid onset, pain on injection and reduced cerebral blood flow. Unlike barbiturates, involuntary movements, better cardiovascular stability and less respiratory depression. Major drawbacks are nausea, vomiting, increased motility due to suppression of adrenocortical stress response. Then methotrexate. It is similar to thiopentone but is more potent as compared to thiopentone. Now we are going to discuss about a very important phenomenal dissociative anesthesia. The most important example of dissociative anesthetic is ketamine. This ketamine causes moderately rapid onset and recovery. It causes dissociative type of anesthesia which is characterized by catatonia, amnesia and analgesia without actual loss of consciousness. It is the only anesthetic that produces cardiovascular stimulation. So heart rate, blood pressure and cardiac output are increased. It is a useful anesthetic agent for high-risk geriatrics patient and the patient in shock. It causes emergence phenomenon during recovery which is associated with disorientation, sensory and perceptual illusions and vivid dreams. The advantages of ketamine provide profound analgesia and can be used as the sole agent for minor procedures. Respiration is not depressed, does not induce hypotension. Pharyngeal and laryngeal reflexes are only slightly affected, means that is not abolishes. Less likely to induce vomiting. So this is very important. It is of particular value in children and poor risk patient and also in asthmatic patient as it does not induces bronchospasm, which is very important point. Disadvantages may be dangerous in hypertensives as it raises blood pressure by enhancing cardiac output and heart rate. Hallucination and involuntary movement may occur during recovery if used as a sole agent. Contraindications: hypertension, congestive cardiac failure, cerebral hemorrhage, increased intracranial tension, psychiatric disorders and pregnancy before term. These are the contraindications. Specific precautions: pulse and BP should be closely monitored. During recovery, patient must be undisturbed and under observation. Then come to neuroleptic analgesia. A combination of fentanyl and droperidol is used to produce neuroleptoanalgesia. The fentanyl, it is a short-acting 30 to 50 minutes and potent opioid analgesics related to pethidine. Droperidol, it is a potent and rapidly acting neuroleptic antipsychotic related to haloperidol. When the combination is given by IV route, a state of neuroleptoanalgesia is produced. This state, which is called neuroleptoanalgesia, is characterized by quiescence, psychic indifference and intense analgesia without loss of consciousness, and this phase lasts for approximately 30 to 40 minutes. This fentanyl 0.05 mg plus droperidol 2.5 mg per ml 4 to 6 ml is infused IV over 10 minutes. Patient become drowsy but cooperative. Respiratory depression is present. There is a slight fall in BP and heart rate. Vagal stimulation is because of. During recovery, EPS may be seen due to droperidol. It is indicated and suitable for endoscopies, burn dressings, angiographies, and other diagnostic and minor surgical procedures. Another important terminology is neuroleptoanesthesia. Neuroleptoanesthesia, this is produced by addition of 65% of N2O nitrous oxide, which is laughing gas, plus 35% O2 in the above combination produce neuroleptoanesthesia. Now come to benzodiazepines. Benzodiazepines includes midazolam, lorazepam, and diazepam, which are used. Their onset of effect is slow and recovery is also slow. They causes anterograde amnesia. Half-life period is approximately 15 to 20 minutes. Now these drugs, these benzodiazepines, are used as a pre-anesthetic medication for intraoperative sedation and with other drugs as a part of balanced anesthesia. Benzodiazepine may be employed alone in procedures like endoscopies, reduction of fracture, cardiac catheterization, and cardioversion. IV midazolam is particularly preferred as it is a fast and short-acting, more potent, and does not cause pain or irritation at injection site. Benzodiazepines are also used for induction and maintenance of anesthesia. In conservative dentistry, nitrous oxide plus oxygen plus diazepam, this combination is very popular. So inhalational anesthetics, anesthetic halothane, advantages: non-inflammable, potent, non-irritating, enfluent, little change in pulse or respiratory rate, smooth adjustment of depth of anesthesia are possible, adequate skeletal muscle relaxants. Isoflurane, depth of anesthesia can be rapidly adjusted, cardiac output sustained, arrhythmias uncommon, potentiate action of skeletal muscle relaxants. Desflurane, very rapid induction and recovery. Oxygen toxicity is negligible. Nitrous oxide, non-inflammable, non-irritating, rapid onset and recovery, little toxicity. Diethyl ether, good skeletal muscle relaxant. Now we'll discuss about the pre-anesthetic medication, which is very important, and in examination short note may be asked on this particular topic. What is pre-anesthetic medication? So pre-anesthetic medication, this is given prior to administration of the main anesthetic agent in the patient in order to, number 1A, relieve pre-procedural anxiety, B, to relieve pre-operative pain, C, to potentiate the degree of analgesia and also produces amnesia, D, to reduce the side effects of the anesthetic agent used, to reduce the quantity of anesthetic agent required, to reduce bronchial secretions, bradycardia, and the last one, to reduce the incidence of post-operative vomiting and also reduces gastroesophageal reflux. The drug used for these purposes are, means in pre-anesthetic medication, the drug used for the following purposes. Number 1, sedatives and anxiolytics like diazepam, lorazepam, cetuximab, nitrazepam. Then B, antiemetic drugs like promethazine, chlorpropamide, all these are used. C, analgesics like morphine, fentanyl, pethidines are used. As an anticholinergic, atropine, hyoscine, glycopyrrolate, these are used to reduce secretions and prevent cardiac arrest during induction of anesthesia. S2 receptor blocking agents like ranitidine, roxetidine, these are used to reduce gastric acid secretion and prevent aspiration of gastric contents. Then pre-anesthetic medications can facilitate an uncomplicated anesthetic and operative course by improving the rapidity and smoothness of induction, reducing anxiety, providing analgesia and amnesia, and compensating for the salivation, bradycardia, and other side effects of anesthesia. Number one, sedative hypnotics. Tranquilizers such as diazepam are very useful in a wide variety of anesthetic situations. They can provide pre-operative sedation, help to prevent and treat CNS stimulation caused by local anesthetics, and provide amnesia. Barbiturates such as secobarbital and pentobarbital are the preoperative sedatives most frequently employed. These agents produces less postoperative nausea and vomiting than opioids. Number two, opioids such as morphine, fentanyl, and alfentanil often are given to patients who are to be anesthetized with general anesthetics of fairly low potency, such as the combination of nitrous oxide and thiopental. In addition, they can be administered with a barbiturate or diazepam for the regional anesthesia. In both instances, they provide analgesia. Alfentanil may also may offer advantages over fentanyl for longer procedure responses, and recovery appears to be more rapid. Then phenothiazine derivatives such as promethazine and antihistamine hydroxyzine often are administered concomitantly with opioid because they potentiate the analgesic effects without increasing the side effects. Anticholinergic agents, they are used to number one, reduce the secretion, number two, to prevent bradycardia with due to vagal stimulation, then prevent laryngospasm which is due to excessive secretions. Atropine and scopolamine as well as the quaternary ammonium compound glycopyrrolate are used routinely to decrease the flow of saliva. Because of a lower incidence of undesirable side effect, glycopyrrolate is recommended as the anticholinergic agent of choice for bronchoscopy. B. Drugs that reduce acidity. S2 blockers like ranitidine decreases gastric acid secretion and are given on the night before surgery. Decrease in gastric secretion reduces the damage to the lungs if aspiration occurs while on anesthesia. C. Gastrokinetic agents that metoclopramide is a domperidone or dopamine antagonist that promotes gastrointestinal motility and increase the tone of esophageal and of the stomach. This speeds gastric emptying. The combination of H2 blockers plus metoclopramide provide best protection against aspirational pneumonia or aspiration. Thank you.